All right, so welcome everyone. Thanks for joining us for the May 2017 CDA vendor webinar. We want to extend a special welcome to our blood bank vendors and any other vendors that may be joining us for the first time. Along with the usual patient safety and dialysis component information, we will also dive into the hemovigilance component. As I said, I'm Mindy Durrance, and we'll be presenting along with my colleagues, Dr. Dan Pollock, Alexandra Savinkina, Casey Thompson, Amy Webb, Wendy Wise, and Ahmed Tahir. Just as a reminder, please mute your phone and please do not put us on hold. If you need to take another call, please hang up or disconnect from the Skype call and dial back in when you're ready. Please hold all questions till the end of the presentation. And then, as we noted before, we are recording the webinar, and we'll turn off recording at the end when we open it up for questions. The webinar will be posted on the NHSN CDA submission portal for future reference, and we'll let you know when it's been posted. We have a lot to cover today, so Dr. Pollock, please start us off.
Thanks, Mindy, and hello, everyone. I'm going to provide some NHSN updates. Many of you are aware that the APIC conference, the Association of Professionals in Infection Control and Hospital Epidemiology, is coming up in June in Portland, Oregon. As in past years, we will have presentations and meetings. I want to highlight on the presentation front the presentation that Amy Webb will be doing on the AU and AR options in NHSN. For those of you who are somewhat familiar or not familiar at all with the AU and AR option, this would be a great introduction. For those of you who have familiarity, Amy will be providing web updates as well. Then we have our NHSN members meeting. This is for the infection preventionists and other NHSN users who attend the APIC conference, and we review upcoming changes and other NHSN developments. And that members meeting is Thursday afternoon, June 15th, beginning at 5 o'clock in the Oregon Ballroom. So the next slide. We want to remind everyone on the call who signed up to meet with us in person that we have scheduled one-on-one meetings with vendors who've expressed interest and accepted invitations to confer with us on site. We do have openings on Tuesday for any companies or organizations that would like to schedule a meeting with us to discuss the directions we're taking, questions that they may have, just an open-ended conversation with us. You're welcome to send us an email at the email address listed here, and we'll get back to you to schedule a conversation on Tuesday the 13th. Next slide. So I wanted just to make some brief announcements about NHSN itself, starting with our release schedule. We are going to continue one major release a year, and as in years past, our effort will be to have this release go live around January 1st to include all the NHSN surveillance protocol changes that go into effect with the new calendar year, and also to transition to new CDA versions that are due in part to the protocol changes themselves. We are going to be introducing component-specific NHSN deployments after this coming August. That will give us greater flexibility and agility to move forward with changes in individual components and decouple the releases from the releases of other components. And we have, in addition, 3 scheduled non-major releases a year that may include minor defect resolutions, minor change requests, infrastructure maintenance and support. The next slide. So the scheduled releases for 8.7 in June, and all changes will be effective immediately after the deployment. And then another release, our big release in December 2017. This is the one that's timed to be close to January 1st. The Defects defects effective immediately post-deployment will be addressed, and CRs with effective dates will be effective January 1st. Change requests with effective dates will be effective January 1st, 2018. Next slide. So we've been at the whole business of importing CDA data into NHSN since 2009, and we're continue to make great strides in terms of the amount of data that's arriving via CDA, and just wanted to highlight some of the metrics there. On the numerator front, you can see on the left-hand side of this slide that 37% of the bloodstream infection reports are arriving via CDA into NHSN, and the most of the numerator data that are arriving via CDA are for laboratory identified events. On the denominator side, on the right-hand side of the slide, you can see that we don't have quite as much in the way of data arriving via CDA, but still a considerable amount with some of these denominators, a fifth of them arriving via CDA. So one way to look at this is that we've made great progress. Another way to look at it is that there's more opportunity ahead, including more business for vendors on the call, where there are opportunities to expand the amount of data that are arriving to NHSN via CDA. So I think that's my slide coverage, and we'll have opportunities, as Mindy said, for questions and discussion at the end of the program. Turn it over to Alexandra for the hemovigilance module and electronic reporting.
Hi, I'm Alexandra Svinkina, and I work with the hemovigilance module of NHSN. So next slide. So as we all know, NHSN is a surveillance system operated by CDC that started with the purpose of tracking healthcare-associated infections, and then expanded its mission to include tracking other things, including transfusion-related adverse events. There are 5 components within NHSN, and this includes the biovigilance component, and then within the biovigilance component is the hemovigilance module. This is where we collect recipient hemovigilance data. Next slide, please. The NHSN hemovigilance module was created to implement national surveillance of transfusion-associated adverse events aimed at improving patient safety, minimizing morbidity and mortality of transfusion recipients, and identifying emerging complications and pathogens associated with blood transfusion. The hemovigilance, next slide, sorry. The hemovigilance module captures 12 transfusion reactions as listed on the slide, and the hemovigilance module also captures transfusion-related incidents, including process errors or deviations. Next slide. We collect 4 types of data. The facility survey is reported annually, and it's used to describe facility characteristics. For example, community setting, total number of beds, and annual surgical volume. Reporting denominators are reported monthly, and they're reported by product type, collection method, and modification. Adverse reaction reports are reported for each event. Adverse reaction data includes patient information, reaction details, adverse event classification, and blood component details. And then incident reports are only reported if associated with a transfusion reaction. This includes event discovery data, like the time of the incident, and then process steps where the incident was discovered. Next slide. At this time, all data is manually entered by each facility. This process can be time-consuming depending on the transfusion volume and the number of reactions the facility has. This has affected participation in the hemovigilance module, in that facilities have stated they would need an additional full-time employee to participate. Those facilities that do participate have difficulty reporting during staff shortages or when an NHSN trained person leaves. Data quality is potentially affected by manual data entry, and transcription errors could occur, as well as inconsistent interpretations of data required by facilities. The data we collect is limited by the need to reduce the time commitment required for reporting and ensuring the highest level of data quality. Additionally, adding data elements such as new blood product modifications is prohibitive. Next slide, please. The monthly denominator form is one of our more time-consuming forms. It asks facilities to list the total number of transfused and discarded products by type, total number of patient samples, total number of cross-match procedures, and total patients transfused. This form is used to calculate the denominator for transfusion reaction rates. The information comes from the blood center computer and is completed on a monthly basis. Currently, the reporting method used by facilities includes a paper form for internal data gathering and then manual data entry into the NHSN application. Next slide, please. The main table of the denominator form is on this slide. Facilities gather and manually enter data for each cell on the form. Next slide, please. Additionally, we have some facilities that report transfusing blood products treated with pathogen reduction technology, in which case they also complete the two tables shown on this slide. The feedback we have received regarding this form is that it requires more time than other forms we have to complete. Next slide, please. There are also additional data elements collected on the denominator form, some of which are required, as shown at the top of the slide, as well as optional data elements. And for convenience, facilities have the option to report no adverse reactions or incidents. And these data elements correspond with the numerator. Collecting these data elements on the denominator form prevents additional keystrokes for facilities to report this data on a different page. Next slide, please. Electronic reporting addresses limitations of manual reporting. Electronic reporting would reduce the time required by the facility to complete reporting by about 97%. The burden of data collection is then shifted from the facility to the electronic reporting software, and it would take about 2 minutes for a facility to report the denominator data electronically. This would improve our data quality, as there would be a standardized process across all facilities and all users, eliminating interpretation inconsistencies. This would also eliminate transcription error, and it would allow us to collect more descriptive data with no increase in time requirement. Clinical Documentation Architecture, or CDA, is how we are going to implement electronic reporting. It's a standardized code structure that allows for data exchange. Next slide, please. I'll now walk briefly through the data flow for electronic reporting of the denominator form using CDA. The facility blood bank computer system contains ISBT product codes and descriptions on transfused products. Next slide, please. The ISBT codes and descriptions are uploaded to the NHSN application through the facility's CDA. Next slide, please. The codes within the NHSN application are then mapped to ISBT product formulas. Next slide, please. ISBT product formulas contain information on the type of product and any modifications to the product. Next slide, please. So the ISBT product formula directly maps to the NHSN denominator form with both product type and the modifications we ask for. Next slide, please. Additionally, the ISBT product formula adds additional information that's not collected on our manual entry form, such as the core conditions of the product, whether it has been washed, and whether it has been opened. Next slide, please. In addition, the facility's blood bank computer system also contains information on other required and optional data elements on the denominator form. These can be uploaded to the NHSN application by the facility's CDA as well. Next slide, please. And this maps directly to the additional required and optional questions on the denominator form, as shown here. Next slide, please. So in conclusion, manual reporting has limitations, and electronic reporting would address these limitations, including using CDA. Facilities could electronically report denominator data via CDA to the NHSN Hemovigilance module, and the CDA implementation guide is available to vendors. Our next steps are we're hoping that vendors will use the implementation guide to develop CDA for their software for facility access, and we're happy to continue discussion of CDA among blood bank software vendors and facilities. And now I'll pass it off to Mindy, who can give you a little bit more detail.
Thank you. So my next slides are going to be sort of a follow-up to Alexandria's on hemovigilant CDA reporting. So bear with me, all you seasoned vendors, get into a little bit what is CDA for our new blood bank vendors who are joining us. So it stands for Clinical Document Architecture. It's a Health Level 7 standard, and it provides a framework for encoding, formatting, semantics, electronic documents. And it's an XML format. You can see a little snippet there. Based on HL7 guides, and we also, as our program, supply supplemental information that you will need to perform your job on your side to create the CDAs and so on. Next slide. So the present CDA we have is currently based on the R3D1 IG. That got rolled out in January of this year, and we're already moving it to the R3D1.1 IG version, and this is to add the Zika-related fields that got added a while back. I think this is going to be the stable version for a while, so I think it would be a great time for the vendors to start working on it. Next slide. Just a quick view of what NHSN reported via the electronic method. If you can see that the data is collected from laboratory, blood bank, information systems, and also ADT systems, and actually there's more than this, pharmacy systems and so on. The information on your side goes to the vendor system, and the vendor does their thing, and then there's two modes of transport. The information to the NHSN is via direct CDA import, which actually uses a health information service provider. And we'll get to those slides if you want more information. We'll talk about how you can we can help you there. And then manual CDA import, which is where the user logs into the NHSN application and actually imports their CDA into their facility. The user still has access to do all the other tasks. They can do reporting, they can do analysis, data sharing, and so on. Next slide. So who creates the CDA? It's usually the vendor CDA software system. The CDA import is used in all 50 states. If you're interested, or a facility, or there's sometimes users on here, you want to know more about it, you can talk to your infection preventionist. Also see if your facility already submits HAI data, and also check with your chapter, APIC chapter for your state. They often have information on different on vendor CDA systems. Some hospital IT departments have created CDAs without commercial vendors. We would call those do-it-yourself or homegrown. If you're a new vendor interested in creating CDAs, we'll give you information on where you can send emails to the NHSN CDA mailbox, and we'll help you get going, have webinars, conference calls, and so on with you. And for this CDA, the Hemovigilance Denominator CDA, is actually the first CDA import for the biovigilance component. So that's another good milestone for the program. Next slide. So as Alexandria said, what's it going to add to my data? Actually very granular data that's unable to be collected and inputted manually. The CDA includes data required for the entire hemovigilance denominator form, if you think about the paper form, plus the ISBT data that will be in the CDA. It has, all our CDAs have business rules. A common one in this Actual CDA is the ISBT data is required when specific blood products are greater than 0, and that would be for all the columns listed on the form: units transfused, aliquots, and total discards. Next slide. So without getting too far into the weeds, just wanted to give you a little comparison snippet of the code. So if you look in the on the paper form for whole blood highlighted in orange, you'll see it says whole blood total units transfused was 5, and then in the snippet of the XML, you'll see it displays the format of how the CDA would look for total numbers of units transferred, and your value equals 5. Next slide. And then to go one step further, if you could imagine, of course, under the orange also, if you'll see whole blood equals 5, and under that, it's okay, how many ISBT blood products were there, and there was a total of 5, and you'll see the one highlighted in green says number 2, and then that's the snippet of code down below. So now we're getting down to more granular, and you'll see the whole blood for ISBT 128, the code E0009, and it shows the value of 2. Next slide. So as I mentioned before, the ISBT data is included for specific blood products greater than 0. We have, how do you know? Where's that guidance? We have it in the protocol. It's in the XML samples, and it's in the supplemental documents. And here's a little snippet of the paper form. And I know you guys are used to this. We call them commented or mocked up forms. And we have included all the database variables, the codes, and whether or not on the far right you can see check ISBT on edit or for the ISBT codes. And there is a supplemental Excel workbook with all these tabs that have all the vocabulary value sets for each of the blood products. Next slide. Sorry, yeah, there we go. So the ISBT data is displayed via analysis and reporting function. So as you know, you enter your data, then you have to generate data sets. From that, you can go to on the navigation bar, you click on analysis, and then you can click on line listing for hemovigilance denominator ISBT data. And then as you see in the screenshot, your report displays the ISBT data that was for that summary. Next slide. So what can you do now? If you're new to CDA, you can start gathering your resources for development, data validation, implementation, or you could work with an existing CDA vendor. If you are a new vendor or interested and are doing it yourself, we highly recommend that your development staff are familiar with HL7 and XML. It is a complicated task, and you need a really good basic knowledge. On the website, we also have toolkits. We have protocol. The implementation guides will point you to that. We send out the information data model called the IDM and other supplemental documents that are provided. Next slide. This is just a quick run through we share with all the vendors. Just to give you a high-level idea of the steps that, to complete the task to import CDA successfully. First of all, the ability to collect the data, understand the NHSN protocol, review the related tabs in the IDM that we mentioned, create the CDA based on the specific implementation guide version. There's a validation site that Lantana provides, and they are the creators of our implementation guides. That's very useful to validate your CDA. And then complete your successful CDA import into a test facility and then into a real facility. And then once you get all that, then you can move on to direct CDA automation. Next slide. So how do you keep up with all this information? You can request to be on the CDA distribution email list. Send an email to NHSN CDA@cdc.gov, and we'll be glad to add you to our distribution list. And then also we provide the link to our CDA portal where we have a lot of useful information. Next slide. And I'm going to turn it over to Casey.
Thanks, Mindy. Hello, everyone. My name is Casey Thompson, and I will be discussing the defects and changes that will be implemented in the AUR module with Release 8.7. Next slide, please. Defect 4421 is correcting an AR succession management error message. Currently, when users upload an AR denominator file without correctly using succession management, they are receiving a generic error message stating an error occurred updating the database. The corrected error message is more specific and mentions using succession management to update. Despite this defect, the AR summary files will import correctly when using succession management. This error message only appears when succession management is not used. Next slide, please. Defect 4480 impacts AU and AR multi-facility CDA files sent via direct. When files for different facilities are mixed together and sent via direct CDA automation, they're failing import into NHSN. Once this is fixed, the zip file may contain AU and AR files for multiple facilities. Until the 8.7 release, please only include one facility per zip file sent via direct. Next slide, please. Defect 4482 is in the NHSN UI and has no CDA impact. Currently, the optional email address on the AUR Meaningful Use 3 registration page produces an error message or will not save if capital letters are used. When fixed, the email address will accept either capital or lowercase letters. The current workaround is for facilities to use all lowercase letters for the email address when registering. Next slide, please. CR 1502 impacts customized user rights for AU and AR users and also has no CDA impact. We've updated the custom rights to allow users to have access to AR events only, which was previously not available. We will be including more details in the June NHSN newsletter so users will know what needs to be updated in their customized rights. Next slide, please. There it is. CR 1769 changed specific wording in the letters sent to facilities for Meaningful Use 3 and in the UI. This change has no CDA impact. Per ONC request, we removed all reference to submit production data within 60 days of registration and submitting data for 1 full year. Now I'd like to turn the next part of the presentation over to Amy Webb to discuss 8.8 AUR defects and changes. Amy?
Thanks, Casey. So first up, we have one new CR 1733, which will be adding 2 new bar charts. Again, there's no CDA impact for this one, but we will be adding these 2 new bar charts. The first will show selected agent distribution by location and month, and the second, as shown a mock-up on the slide here, showing the SARS by location and month. So facilities will be able to see more granular data in the bar charts. CR 1816 is full of pathogen updates that Mindy will talk about a little later on, but as it relates to the AR option specifically, we'll be adding these 6 new ESBL-specific SNOMED codes here, as you can see on the slide. So all 6 of these will roll up to the pathogen without the susceptibility description, but you will be able to use these specific ESBL SNOMED codes with the 8.8 release for your AR option data. And then we have one defect that will be slated to be fixed in 8.8. Defect 4499 affects AR events. And as we've found so far, basically when the null flavor fields are used for the specific test results, meaning the e-test, the MIC, or the zone or Kirby-Bauer test in the CDA file, when that very first drug in the CDA file is listed as not tested or NA, then that is showing up as E, just the letter E, in the database and in the analysis output instead of showing up as not tested. It, again, seems to only affect the data when the very first drug in the CDA file is listed as NA or not tested, but thankfully it does not affect the final interpretation, only those specific test results. So on this next slide, I have a screenshot of what it would look like if you were to run the AR event line list. You can see here highlighted in yellow, for this event, it's a Candida auris AR event. The very first drug in my CDA file was amdulodipfungin, and I had NA, or not tested, for my e-test in my CDA file. That imported just fine. However, when it was saved in the database, it saved as E, letter E, instead of NT, or not tested. Alrighty, so next I'm going to turn it over to Wendy Wise.
Thanks, Amy. On these next few slides, I'll discuss a few NHSN topics that may be of interest to you. Next slide. First up is the Antimicrobial Use Synthetic Dataset Project. The purpose of this project is to use synthetic data to ensure that vendor ADT data and medication administration data are aggregated correctly according to the NHSN AUR module AU option protocol. This project is not intended for testing or validation of CDA files, though. The test data or synthetic data set is provided by the NHSN team. Participating vendors will load the test data sets into their database and process it just as they would their own real data, generating monthly summary data. Vendors would then upload this monthly summary data to a CDC web application for validation. This web application returns validation results automatically and instantaneously. The feedback consists of incorrect rows, if there are any, and possible reasons for the errors. Next slide, please. So far, we have 5 vendors participating in this pilot of the project. They all have received instructions, the test data, database schema, etc., in order to pilot. We anticipate some of the vendors will begin submitting summary data for validation very soon, possibly in June. We hope to learn from each vendor as we go forward how we can improve the pilot, with the intention of eventually making the synthetic data, the web application, and the processes available to all vendors to validate the aggregation of their AU data. This could be beneficial for you as vendors before beginning submission of CDA files into the AUR module of NHSN, or for validating aggregation of data after updating or even changing vendor systems. We welcome more vendor participation. If you'd like to participate, feel free to contact me. My email is listed here. We do have a 20-minute video that demonstrates uploading the synthetic data into an example vendor database and then submitting the AU output summary file to the web application for validation. It's a pretty large file, too big to email, but if you're interested in viewing it, I can work with you individually to find a good way to share it. We've used Dropbox before, or we can figure out something that'll work for you. Just contact me. Next slide, please. All right, I'll give a brief update on the NHSN AUR module for Meaningful Use Stage 3 next. 5 facilities have signed up thus far. If you're a certified vendor for the Medicare and Medicaid EHR incentive programs, you can double check that you're on the list by searching using the Certified Health IT Product List, CHPL, and the link is provided here on the slide. Also included is a URL for the overview of CHPL. The overview website contains a section called For EHR Developers, and it provides information on how to be listed on the CHPL list. I'd also like to point out we have a new document on the NHSN website for facility level MU3 guidance that is beneficial for you as vendors to review, since your facility will likely be reaching out to you for help on meaningful use. You can see the URL listed on this slide, but in brief, this document highlights 3 steps for facilities: how to register intent to use the NHSN AUR module for meaningful use stage 3, how CDA test files containing no PII data are to be sent to the NHSN team, which still must be done even if the facility is already submitting AU or AR data into NHSN. The third step is when the facility passes validation and is deemed ready to submit to production. Next slide, please. All right, we have several new resources on the NHSN website so far in 2017. I've listed some key ones here. The AUR module training slides included adding 2017 updates to the AR option and adding details regarding the monthly reporting plans and CDA upload. The AUR module protocol included adding clarifying text regarding counting patients in a single calendar day. The AU option analysis training video demonstrates how to run the default AU option reports, as well as how to make modifications to those reports. So these resources are very helpful to facilities, but as vendors, you may want to review them as well for background information when working with facilities for reporting AUR module data to NHSN. Next slide, please. Wanted to point out another resource update. So we've updated the previously existing 6 quick reference guides with new screenshots and processes for the NHSN version 8.6, which was released earlier this year. We've also added 2 new QRGs, the SAR table by location and antimicrobial resistance line list. Not only are these reports valuable to facilities, as you can imagine, for analyzing their data, but facilities or you as vendors could use these for QA and validating the data. Next slide, please. You may have heard of the Society of Infectious Diseases Pharmacists in their website, which is listed at the top bullet. This website contains a list of software vendors that have self-reported successfully submitting data into the NHSN AU and AR options. As vendors, it's important that you keep information on this website updated because the NHSN team often refers users to this site for a list of AU and AR vendors. If you're not on the list and you're interested in submitting, or if you are working towards submission of AU or AR data, you're encouraged to contact SIDP to be placed on the list. And now I'll turn it over to Ahmed for a review of the dialysis component updates.
All right, thanks, Wendy. Hi, everyone. My name is Ahmed Tahir, so I'll go over dialysis components. If we could go to the next slide, please. All right, so the first defect we have is 4396. This defect does not have any CDA changes. The issue that was corrected was a 21-day rule was being applied to CDA dialysis events with event dates less than January 2017 and going back to 2016. What should have been applied was January 2017 and beyond. You can refer to the 8.6 IDM and protocol for the business rules that are documented. All right, next slide, please. So this is going to be for our 8.8 changes release that we have coming out at the end of the year. For the first one is CR 1581. We're going to be implementing the new CDA dialysis numerator, and we're using the R3D11IG. Currently for 2017, we are on the R3D1 data. And so what this is going to do is anything from 2018 and beyond will use the R3D11 version of the IG. We added an additional question to the dialysis numerator CDA. If new antimicrobial start equals yes, then was a blood sample collected for culture will now be required. And if you look for it on the mocked-up form, the code is 2339-0. And again, this import will begin from January 1st, 2018. You can also refer to the toolkit. This has not been posted on the website yet. We will let you know once an update has been made. But from the toolkit, you'll be able to get the R3D11IG, the 8.8 IDM, XML sample in the mocked-up form. Next slide, please. So as you can see here on CR 1581, this is the mocked-up form. Wherever you do see the highlighted the highlights, that's where we made the additional changes. If you look towards the bottom of the form on the left-hand side, that's where we added the new question if antimicrobial start was a blood sample collected. So that will be the new addition for this form. Next slide, please. Again, right here, just to reiterate, so right now this is going to be for dialysis numerator. Events with 2017 or below will be using R3D1 version of the IG. And then again, if you are using the R3D11, that's going to be applicable to anything dated 2018 and beyond. All right, next slide, please. And this is just a good, something good to know for everyone. This is going to be something we're adding in the future. It will be coming from in the 8.8 release, but it will be really implemented and affected the CDA from January 2020. The additional field we're adding will be the acute kidney injury for the patient. Until the CDA catches up, this field will remain optional. And we are slating this to be for the CDA to catch up in January 2020. Next slide, please. Right, and just a couple of the patient safety component changes that we're having. Next slide, please. So for the first defect for 8.7, we did correct an MDRO issue. The MDRO was displaying when there was changes that needed to be made. And also there was occasional issues when attempting to import the valid MDRO summary.
Excuse me, could you please repeat what you just said? There was a cutout on your last statement.
Yes. Yes, so for the MDRO summary, it was appearing in the alerts and incomplete list when there were no issues with that MDRO. Also, when importing valid MDRO summaries for FACWIDE in, there were UI displays, other issues or required fields that weren't showing as required. So we did make those corrections to those errors, and there shouldn't be any more of those appearing in your incomplete list or any of the other issues relating to MDRO. Next slide, please. This is for defect 4410. We're not having any CDA changes for this. The issue we corrected was for ertapenem not being coded for infection surveillance, MDRO, CRE. coli, and CRE. Kleb. The issue that was happening was you weren't able to save the events with a valid CRE. Kleb or CRE. coli pathogen when drug sensitivity included only ertapenem as intermediate or resistant. And this was affecting BSI, UTI, and SSI events. And again, there won't be any CDA changes needed for this. Next slide, please. For CR 1579, there were updates and corrections made for ICD-10, PCS, and CPT codes for 2017. This was sent out by the NHSN CDA mailbox. You can find this in the CDA impact notes and also in the supplemental document that was distributed a couple weeks ago. For CR 1654, an alert message was added for Candida auris being reported via CDA. And again, this will not have any CDA changes for this CR. Events that shall be listed in alerts and incomplete tab until the user goes in and verifies. So this is something that the vendor should not be going in and doing, but the users will go in on their end and just click on verify, and then this will also remove it from the alerts and incomplete tab. And again, this does affect BSI, UTI, and SSI. Next slide, please. And so a couple other CRs. This is related to CDA direct automation. For the first CR 1710, we are increasing the size of the CDA. Currently, it's listed as 1 megabyte or 500 XMLs, whichever comes first. And we did increase that size to be 2 megabytes or 1,000 XML, whichever comes first. This will affect anything that is CDA related and anything that's being imported via direct. For CR 1739, hopefully you guys did notice some changes and increase in the speed of direct messages being processed. This was included in a couple of in our previous deployment, and we are making more maintenance and other changes to this as well. So hopefully the messages being processed per minute should increase. Again, this is also based on how many messages are in the queue. So of course, the more there is, the slower it might be, but the less there is, and the faster it should come across. All right, and I will hand it over to Mindy. Thanks.
Thanks, Ahmed. So we'll say Ahmed's my new coworker who is here to help me with the huge CDA task. So thanks, Ahmed. So next we'll get into still again patient safety. Now we're on to release 8.8 changes. And just to recap, thinking back to Dan's slide, 8.7 is scheduled to be deployed June the 17th, so Saturday. So that's in, 3 weeks from now? And then the 8.8 is released, will actually be released in December, but the changes as we get to the defects will be effective immediately, and any yearly or protocol-related CRs will go effective January the 1st. So just keep that in mind as we go through these slides. So the first one for 8.8, which is, like I said, January 18, 2018, is for MDRO summary. So a new C. difficile test method question has been added to be required for 2 inpatient rehab locations. And that's also if the CMS IRF equals yes. There's the location codes right there. They're rehab and rehab pediatrics. It is the CDA test type is expected to match the FACWIDE-N MDRO summary. So for your side, for CDA import, if CDA test method does not match, the summary will actually go to the alerts, and they're making a new one, alerts for CDIV test method tab. And the user would need to log on and verify whether they agree or, approve if it matches, if it does not match, sorry. So just want you to be aware of that coding that you'll have to add for those locations. Next slide. So the next 2 actually CRs are for SSI and GI events. As you know, GI events are not CDA import, but the SSI is. But there's been an update for IAB specific criteria definitions, and this is per the protocol. In this example, I wanted to explicitly go down and you see the scenario. So the 2 specific criteria that have been added are hypotension and elevated transaminase levels that have been added. Well, these actually are both considered as SSI other. So if you think about the paper form in your CDA, the scenario will actually save in the user interface or for CDA with only 1 SSI signs and symptoms for other and 1 of the laboratory criteria for the protocol. So you can see that in the IDM as you know, on the specific criteria business rule tab. Next slide. Next one is also SSI events. As I said, it affects SSI and GI if you're helping people do manual entry for GIs. But there's been an update on the GIT specific criteria definitions, and they've added it, as you see there, to 1B. And you can also see that in the IDM for your business rules. Next slide. So there will be another ICD-10 CPT codes update for the January 2018 release. If you have taken a peek at the IDM that was distributed, you'll see there's an empty tab there. So we are waiting for those codes to be released, and as I understand it, the CMS does not release those codes until the fall. So it's moving fast on our side too, but we will get them to you as soon as we can and include it in our coding. So just be on the lookout for that, those updated ICD-10 codes. Next slide. So we have 3 CRs that are pathogen and business rule updates. And we'll talk about each of them separately, but my first in bold is the new pathogen list and business rule will be versioned. And I'm going to stop right there and say it again. The new pathogen list and business rule will be versioned. This is the first time that we have actually versioned the pathogen tab in the business rules. So we'll be interested to see how, get y'all's input, but hopefully it will be easier for you to have an ending and start date. So to recap, event dates with greater than or equal to 2018 must use the 8.8 IDM pathogen code. And it says pathogen code 2018 list and the business rules. And any event dates with less than 2016 must use the existing pathogen code tab in the current IDM. So even if it's edited, if a 2000, like a BSI with a 2017 event date is edited, it will still use the old pathogen code tab. And as I said again, it'll be the first NHS release in which the pathogen code tabs are versioned. That was included, the new tab was included in the recent IDM that was sent out. So hopefully we gave y'all enough time that you can start working on it. Next slide. All right, so the first of the 3 we'll talk about is CR 1688. It's to remove specific genus and species from the LCBI, which is laboratory confirmed bloodstream infection. This also affected the MBI column too. You can see in the little display there, we have it pointing to the columns in the that are on the pathogen code tab. It includes the list of pathogens that are listed, and it just affects the BSI. I think there's around 130-ish that were changes made. Next slide. The next one, 1785, was to update common commensal pathogens. I think 131 pathogens were added to the common commensal list, and it also only affects the BSI event. Next slide. So this was sort of a catch-all for things that we had floating around that needed to be changed, or we had a few additions we wanted to sneak in. So CR 1818, the addition of rhinovirus, I believe it was first a local code, and then we took it out, and now we actually have a SNOMED code, so it's been added back. Addition of extended spectrum beta-lactamase pathogens. These were mentioned in the under the AR slides. Some few minor corrections. And the events affected are the ones listed below, plus it got cut off, but the AR events are also included in this. We also included some of the specific events or things that are not CDA related, that don't have valid CDAs to import, but I know a lot of y'all will help them with other things than CDA, so hopefully you can update your information. Next slide. The extended spectrum beta-lactamase pathogens roll up to the primary pathogen without the susceptibility description. And I just want to remind you that these pathogens are also listed on the MDRO definitions, so make sure you go there, include that in your code. They do have a different SNOMED code, but the business rule is there. Next slide. NHSN program has a vocabulary now, which is a wonderful addition to the program. One of her big tasks is actually the pathogen codes tab. And so she had added on many tabs in her working Excel, and I thought they would be helpful to you as the vendor, so I actually kept some of them in the IDM. But I wanted to just quickly explain what they were. In column A, there's an NHSN internal sort, and it's sorted by pathogen name, like bacteria, fungus, virus, parasite, prion, and then alphabetically by genus, species. 3 columns were added for patient safety component protocol, and that includes their coag-negative staph, viridins, group strep, and Enterobacteriaceae. So I thought those would all be helpful to you. And then, as usual, our new column AD, which is our new SNOMED codes, or a list of valid codes to be used for January 18 events. So those are new ways you can sort. I do suggest you just keep an eye on the NHSN internal codes, the ones with the asterisk, and just be aware that anything with an asterisk always rolls up and saves as the pathogen listed without the asterisk, in case there's any confusion, questions from your users. Next slide. I know many of you do VAE for your customers, so there is a small change coming. The APRV field is changing from conditionally required to optional, and actually it's in quite a few of our forms. The VAE event, and I have no CDA impact yet, because as y'all heard, it's coming. The ICU other summary and the SCA summary. So, so make sure you have include that code in. If you're still sending it, that's great. We'll accept it. Next slide. A couple more good to know. So in CR 1700 for the BSI event, and you're going to see this on the BSI user interface in January, 2 new fields are being added. The extracorporeal life support present and ventricular access device, both of those are being added to the user interface. The BSI will catch up, and those fields will be added to the next CDA, so that'll be released in January 2019. Next slide. Next is just some general information. I know it's just part of our usual presentation, just to try to keep y'all updated on other things that are going on in NHSN. Direct CDA automation updates. We're up to 13 vendors and over 5,000 facilities sending via direct. So we really are increasing. For those of you who don't do batch direct yet, it is a batch submission process. There is no immediate reply, but as Ahmed said earlier, we are getting faster and creating better processes on our side. And the turnaround time is based on the volume of messages in the queue. If you're new to direct, are new or want to learn more about implementing Direct, there's a toolkit on our NHSN website. And before you get going, we really do recommend you schedule a call with us. We've had a lot of lessons learned and discuss the process, and we actually grab our developers and our Direct administrators to get on the call with us to talk, if you want to talk the details and get in the weeds. Next slide. So just some general information. Thanks so much for your feedback for the ICD-10 updates. I think it's painful for everyone, but it is something we're going to have to keep using and move forward. So as I said, each version comes out, and then there'll be a new version for 2018. So thank you so much for your feedback. And then also thank you for your feedback when we put out from our pre-prod site. We appreciate any edits or things you see wrong to help us improve our system. We've ran into a few issues. We just wanted to make sure this was on your list. This is for you vendors when you go in to help either a new customer or you are coming into a customer that already had CDA from one vendor and switching to a new vendor system. Make sure your customer continues to report to NHSN during this change. We've had a few that somehow missed that. And then another thing we found, if patient IDs will change, review the guidance on the CDA FAQ page. So basically, I think they're recommending that you make the change at the beginning of a new CMS quarter. But please go to FAQs for more information on that. Next slide. So as always, I think we always have this slide since we've created. We have a great webmaster now. We appreciate all his work. So when in question, you go to the guide to CDA versions. We will support the 2 years. And as you can see there in red, this has not been updated yet for the 2018, but there's the link for the CDA versions. When in doubt to know what to use for which year, what to use, what IG to use, this is where you go. And then as always, for all CDA support, for general information, we have a great page, and there's lots of information on there. Next slide. The pre-production test site, as you know, it's a copy of the NHSN development environment. There's no SAMS credentials required. And if you do not have one and you want to get one, send an email to our mailbox, the NHSN CDA mailbox. For those of you who already have a site, the 8.7 environment will soon be available for testing. Hopefully soon. We're almost looking good, almost ready to deploy it. We'll send out an email, but also reminder at the login, read the important message, and we enter there if there's an effective mock date and so on, or what's ready to be tested. We'll have that when you log in. We are still working on the new site. I'm like 99% positive it will be available in the fall, and we are hoping actually way before that. It's going through security scans and so on at the CDC right now, and we're looking pretty good. It will include stats, so there'll be analysis and reporting available. So those of you who do an A&U and AR will be able to see your data. And now at the HB denominator, we'll be able to see the data imported. So be looking for that. Next slide. So future CDA, so as we've talked about on this webinar, we have the Dallas numerator and the hemovigilance denominator. CDA versions are moving to the R3-1.1 version. Plan for January 2019 is the VAE, ventilator associated event. We're also adding the flu summary, and then the BSI numerator will be updated to include those two fields that we mentioned before. And then moving to the next year, plan for January 2020, we're having an update for summaries, the ICU, NICU, SCA, and MDRO, and the dialysis denominators. We are going to add report no events. And I saw that that question was asked. So the answer is yes. We are adding report no events to those 5 summary report CDAs. And then also for 2020, there'll be the update for the dialysis numerator with the new AKI field added. So we have a lot to do. Next slide. Just a few reminders. We always welcome feedback. We offer individual vendor conference calls. Make sure you're on the NHSN CDA email distribution list. Visit our CSFP, and that's our CDA portal with the picture right there. And then the toolkits and IDM, we'll post them on our website as soon as possible. You should have gotten, we distributed an email last week with hopefully enough to get you going and let you start doing your development and planning also. Next slide. So I think that's it for our presentation. We're going to stop the